Hello everyone. So today I'll be revising medicine questions of INI CET PYQ, that is previous year's question. And I not only this, I'll be covering lot of frequently asked questions. I'll be telling you many of the rank 1 questions. I'll be telling you many of the VVIP topic from which questions always come. And finally, we will do the whole revision only in 5 minutes. Okay, with this small introduction, let us start. This is a question from INI CET 2021. 80-year-old case of diabetes was brought to emergency ward in unconscious state. His blood sugar was 900 mg/%. BUN is 56 mg/%, sodium 135. Potassium 5 millicurie per liter, dry tongue, BP is low. Urine ketones negative. Which of the following hypotonic fluid will you use to treat this marked dehydration? Well, he is asking specifically about hypotonic fluid and he has given the options. Well, I give you 30 seconds to think and answer what is the right answer. Okay. Well, I'm sure you have gone for this answer. This is the most common wrong answer. The right answer is normal saline. And I'm sure it is a big shock. How can be hypotonic fluid as normal saline? Yes, that's the beauty of this question. This question is a frequently asked question. Beautiful question. But before we come to why this is the answer, you got to know some basic concept. Again, I have a question for you. What is the plasma osmolality of this patient? Okay, so let's calculate plasma osmolality. How we calculate plasma osmolality? Sodium plus potassium multiply by 2. Random blood sugar in milligram%, you divide by 18 to convert into millimole per liter. Similarly, BUN in milligram%, we divide by 2.8 to convert into millimole per liter. Well, make a box. I have given you certain boxes. Make this box number 1. All of you do the make a box and do the numbering also. Well, as we know, in this case, sodium was 145, potassium 5, you multiply by 2. RBS 900 mg, you divide by 18 to convert into millimole per liter. 56 is BUN, you divide by 2.8, and this way 300 plus 50 plus 20, 370. So in this case, in this patient, total plasma osmolality is 370 millimole per liter. Now, what is the normal plasma osmolality? 280 to 300. This is box number 2. So the normal, as I told you, osmolality is up to this is the range, and in our case, this is 370, much more than the normal. So in this patient, you will give normal saline first. Why you want to give normal saline? BP is 80 by 50. He is having severe dehydration with low BP. So you give normal saline. Point to be noted, this normal saline is isotonic to normal plasma. But when the osmolality is 370, this normal saline become hypotonic when we are dealing with plasma osmolality of 370. So the right and the best answer is normal saline. And you got 2 boxes. I hope you have made these boxes and do the numbering also. Well, I hope the answer is clear to all of you. Remember, again, normal saline is hypotonic to plasma osmolality in a case of non-ketotic hyperosmolar coma. In this case, the diagnosis is non-ketotic hyperosmolar coma because ketones are negative, so there is no chance of DKA. Ketones are negative. So this is box number 3. So the normal sign is hypotonic to plasma of small t in a case of non-ketotic hyperosmolar coma. Let's talk about question number 2. If a patient has come and his serum sample was taken and reports are as follows. Serology report to be more precise. Surface antigen is negative. IgM core antibody are negative. IgG core antibody is positive. Surface antibody is positive, E antigen is negative, DNA is negative. What is your diagnosis? Again, November 2021 INI CET. There are the 4 options. Remote infection, chronic hepatitis B, window period, pre-core mutant variety. Well, it's a beautiful question. Serology, now this is a question based on serology of hepatitis B. Serology of hepatitis B is a VVVIIIPPP topic. Throughout the world, whichever exam you appear, you always get a question on serology of hepatitis B. So you will be getting a question in your exam. So I'm leaking the paper, but in a very honest way. Very honest way. Imandari se. Well, the right answer is remote infection of hepatitis B. That is option A. But why this the answer? This you will never understand unless we know the basic concept. The basic concept goes like this. This is the time period 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Time period in months. This is the period of jaundice. This is the period of jaundice, J for jaundice. And we know very well that the incubation period of hepatitis B is around 3 to 4 months. So, first of all, we get surface antigen. This surface antigen, it appears in the incubation period, peaks during jaundice and disappear below 6 months. Then come the E antigen. Soon come E antigen, peaks, but it disappears with the disappearance of jaundice. The red color is E antigen. When jaundice is about to go, that time, then IgM core antibody appears. And after that, E antibody appears. Then comes IgG core antibody. It starts rising initially, but actual rise occurs after 6 months. And surface antibody again come after 6 months. So with this scenario, so I repeat a quick recap. Surface antigen start in the incubation period, peaks and comes down. Now come to normal within 6 months. E antigen rises, but it disappears with the disappearance of jaundice. This is the period of jaundice. Then core antibody appears, IgM, then E antibody, then surface antibody after 6 months. IgG may start rising after 4-5 months, but actual peaks come only after 6 months. So this is the serology, very, very important. Well, now before I proceed further, let me show you something. This is the time where surface antigen is disappearing. This is a time where surface antibody is appearing. This gap is known as window period. Disappearance of surface antigen and appearance of surface antibody, this time period is called window period. With this background, now let's talk about serology of hepatitis B. I'm giving you certain points, they are very, very important points. Note down, note down. Best epidemiological marker is surface antigen. Earliest marker to appear, surface antigen. Best marker of acute infection, IgM core antibodies. Best marker of chronic infection, IgG core antibodies. Best qualitative marker of infectivity, E antigen. So what I do, I can rub it out. Anybody want to have a click, you can take a photo of this. Right? I hope by now you have taken the click also. Well, and those who are not able to click some of the photo picture, you can very well ask me. I will give you my email ID. I'll share you some of the slides, especially these slides which are long. Best marker of non-infectivity, E antibody. Best quantitative marker of replication, hepatitis B virus DNA. Window period, as I told you, the time gap between disappearance of surface antigen and appearance of surface antibody. In vaccinated person, only surface antibody is present. Surface antibody presence is safe for blood transfusion. Recovery phase, IgG core antibody and anti-surface antibody and HBe antibody. So they recovery phase, or you can say chronic phase, or we can say remote infection. So in this patient, IgG there is anti-surface antibody is there, IgG core antibody are there. They indicate what? They indicate remote infection. Okay, in remote infection. So again, I am rubbing it out. Anybody want to take a click? You can take. Otherwise, this slide I'll share with you. I'll give you my email ID later on. So now let's go back. Can it be chronic hepatitis B? Well, one more beautiful question. I'm sure many of you have gone for this answer. Okay. It's a remote infection. For chronic infection, what we need, we say, now I want to clarify your point. When we say chronic infection, the criteria is surface antigen should be positive. Surface antigen should be positive and there should be IgG core antibody. These both should be there. In our case, the surface antigen is negative, so this cannot be chronic hepatitis. So that's why at times people commit mistake on this. They simply write chronic infection the way even I wrote it, deliberately, to make you clear there's a difference between chronic hepatitis and remote infection of hepatitis B. Our case is a remote infection. Window period, no. Window period is altogether a different entity, and this is not a pre-mutant variety, no. There's nothing to do with pre-mutant. It's a question on serology. So now you are clear about it, why the best answer is remote infection of hepatitis B. Question 3, again in INI localization of lesion in spinal cord are all except. Well, the right answer of this question is, of course, options are cross hemiplegia, combination of lower motor and long track sign, bladder involvement, and fasciculation at the level of lesion. Beautiful question, spinal cord question. The right answer is crossed hemiplegia. But again, it's again a VIP topic. What is crossed hemiplegia? I give you 30 seconds, write down the answer in your copy. What do you mean by crossed hemiplegia? Quickly write down the answer in your copy. Well, this is box. Cranial nerve involvement on one side and hemiplegia on other side. Suppose left-sided, right-sided. There is a cranial nerve involvement, let's say third cranial nerve involved on left side, and there is right-sided hemiplegia. So this is known as crossed hemiplegia. Cranial nerve of one side and the hemiplegia on other side is cross hemiplegia. This is box number 4. Okay. Now, beautiful, very, very important question, very frequently asked question. Examples of cross hemiplegia. This question come in all the exams. Okay. So, like we have a medial medullary syndrome. Lesion is in medulla and the cranial nerve is involved is 12th nerve. Then we have a Miller-Gubler syndrome. Lesion is in the pons, 6th and 7th nerve. And Weber syndrome, 3rd nerve and midbrain lesion, which example I gave you. So they are the classical, and this is a very frequently exam question. Example of cross hemiplegia, and these the nerves are cranial nerve on one side and hemiplegia on the other side is crossed hemiplegia. I hope things are clear to you. Question number 4. A patient is planned for dental procedure. In which of the following infective endocarditis prophylaxis is not indicated? This is a very easy question. But somehow this question comes in all the exam. It's a easy but a very frequently asked question. Well, the right answer is ASD. Okay. But there's a trick why I included this question is, okay, it is, we all know that in even ASD it can be primary or it could be secondary ASD. Whenever they write ASD, if there is nothing like primary, secondary, it is understood they are talking about secondary ASD. But at times, examiner is very clever. He may write as primary ASD. Since nobody has told us that this in ASD primum, primary is also known as primum. The other name of primary is ASD primum. And this is secondum also. So if it is ASD primum, prophylaxis is needed, but it's not needed in secondary or secondum. Be very careful and be very careful about this question. Well, now why we don't need, we need in VSD, we need in PDA, and remember, in fact, ASD, VSD, PDA. They are all example of left to right shunt, but we do not need in ASD. Why? What's the basic concept? Now come the rank 1 question. What I'm going to discuss just now is the rank 1 question. Well, this is the heart and RA, LA, RB, LB. Pressure here is 0 to 4 millimeter mercury. Right atrium. Pressure in the left atrium is 8 to 12 millimeter mercury. Pressure here in the right ventricle, 25 by 0. In fact, it is 0 to 10, but again, for easy, I'm writing 25 by 0. Here it is 120 by 0. Again, 0 to 10, but I'm writing 0. This is pulmonary artery, 25 by 10. This is aorta, 120 by 80. These are the pressure. Now let us see, let's learn about pediatric. Let's learn about basic concept about left to right shunt. Left to right shunt. In ASD, gap is there. But the pressure difference between these two chambers is very low. The blood flows very slowly, very quietly, because pressure difference is not much. So shunt murmur, nil. There is no shunt murmur. Okay, and what about jet formation? Since the blood is going very slowly, so there is no jet phenomena, so no endocarditis. That's why there is no endocarditis. Now in VSD, this is 120, this is 25. So VSD, huge pressure is a difference. The blood will flow with a great pressure. So you get a pan-systolic murmur. Jet formation, yes. Endocarditis, yes. So that's why you get endocarditis in VSD. Diastolic pressure 0, 0. Both 0 to 10, but again for easy I'm writing 0. So there is no difference. So you do not get any diastolic murmur in VSD. PDA, this is the PDA. Systolic 120, 25. So PDA, you get systolic murmur. What about diastole 80 and 10? You get diastolic murmur also. So that's why you get continuous murmur. That's the basic, why you get continuous murmur in PDA. Jet phenomena, yes. Endocarditis, yes. So easy question was that we don't get prophylaxis. We don't need to give prophylaxis in ASD. But the rank 1 question, now you know why we do not need prophylaxis and why you get a pan-systolic murmur in VSD and why you get a continuous murmur in PDA. Okay, so I hope things are very, very clear to you. Well, now we talk about question number 5. Weber syndrome include all except. Although I did mention to you regarding Weber syndrome, when I talked to you regarding crossed hemiplegia, so where the right answer is, here the answer is superior cerebropeduncle involved. This is not a part, it's not true. Include all except superior cerebropeduncle is not involved. So let me tell you the basic concept. Weber syndrome is a VVIP topic, very frequently asked question. In the stroke syndrome, 2 questions are very important. One is Weber syndrome, other is lateral medullary syndrome. Lateral medullary syndrome. This is also known as Wallenberg syndrome. In fact, this is the most important. In 90% chances that you will be getting this question. So remember, I am leaking the paper to you, but in a very honest way. Paper leak around, lekin imandari se. This is a very, very important question. So let me discuss about Wallenberg syndrome and Weber syndrome. In Weber syndrome, this is the corticospinal tract, so-called pyramidal tract. This is the third nerve. This is the superior cerebellar peduncle. This is the cut section of midbrain. This part of the brain is supplied by branch of posterior cerebral artery. PCA stands for posterior cerebral artery. This is corticospinal tract, so-called pyramidal tract. Now, when this will be involved, branch of posterior cerebral artery, so there will be ipsilateral third nerve palsy. And this is a corticospinal tract which will be go down and cross to other side. So it will lead to contralateral hemiplegia. HP stands for hemiplegia. This is Weber syndrome. Okay. Now let me talk to you regarding very, very important question is lateral medullary syndrome, so-called Wallenberg syndrome. Universal question in all the question, NEET, INI CET, USMLE, MRCP, PLAB, everywhere this question comes. So let me discuss. Now this will be cut section the medulla oblongata. The picture is like this. Okay. This is the inferior cerebellar peduncle. Point to be noted, this was superior cerebral peduncle. Point to be noted, in Weber syndrome, these areas were involved. Superior cerebral peduncle was not involved. But here, inferior cerebral peduncle, this is 10th nerve nucleus, 8th nerve nucleus, 5th nerve nucleus, sympathetic chain, and here is the spinal lemniscus. Spinal lemniscus. Spinal lemniscus is the continuation of spinothalamic tract. Small thalamic tract, where they contain contralateral pain, touch and temperature. Pain, touch and temperature. Okay. Now this part of the brain is supplied by branch of pica. Pica is, write down the full form, posterior inferior cerebellar artery. Posterior inferior cerebellar artery. So stop writing, listen to me very carefully, I'll give you time to write. So how patient will come to you? Ipsilateral cerebellar feature, ipsilateral 10th nerve lesion, 8th nerve, 5th nerve, and Horner syndrome. But there will be contralateral loss of pain, touch and temperature. So this is known as lateral medullary syndrome or so-called Wallenberg syndrome. Now you can write down. In lateral medullary syndrome, ipsilateral cerebellar feature, 10th nerve lesion, 8th nerve lesion, 5th nerve lesion, Horner syndrome. Contralateral का loss of pain, touch, temperature. Make a box of this. This is lateral medullary syndrome. Very, very important question. Okay. So now you are clear about it, that why superior cerebral is not involved in Weber syndrome. So friends, now let me tell you about Benedict syndrome. Let me tell you more about midbrain lesion. So again we go back to midbrain. In midbrain we have a red nucleus. This is a third nerve. This is a red nucleus. Red nucleus. Rather better I draw with the red pen. This is the red nucleus. This is superior cerebellar peduncle. You already have written the name. Now, this is the cerebellum. C for cerebellum. This is right-sided. This is left-sided. So this is cerebellum of left side. It gives afferent to red nucleus of other side. It gets efferent from cerebellum of other side. Yeah. It is giving afferent to red nucleus of other side and getting efferent from red nucleus of other side. Now this part of the brain is again supplied by another branch of PCA. Point to be noted, cerebellum of left side getting afferent and efferent from the red nucleus of other side. And this part of the brain is supplied by another branch of PCA. How he will manifest? Ipsilateral third nerve lesion and contralateral cerebellar. Ipsilateral third nerve lesion and contralateral cerebellar finding is Benedict syndrome. Artery involved PCA, ipsilateral third nerve, contralateral cerebellar feature. Just to remind you, in Weber syndrome also PCA, posterior cerebral artery, third nerve. But here we are getting cross hemiplegia, but here we are getting cerebellar feature. This is Benedict syndrome. Make it these two boxes also. Question number 6, again latest INI CET exam question. Which of the following does not fall into diagnostic criteria for neuromyelitis optica? This is a rank number 1 question. Not known to 90% students, are not aware of this. Well, the options are in front of you. Area postrema syndrome, focal epilepsy, bilateral optic neuritis and acute myelitis. Well, the right answer is focal epilepsy. Neuromyelitis optica, also known as Devic disease, an aggressive form of demyelinating disorder, just like multiple sclerosis. It is a variant of multiple sclerosis. There is recurrent attack of optic neuritis and myelitis. So now what are the points? The features are optic neuritis, acute myelitis, area postrema syndrome, episode of unexplained hiccup or nausea or vomiting. Make a box of these 3 lines. They are rank 1 question. More than 95% people do not know this answer. This is rank 1 question. There can be sometimes acute brain stem syndrome or symptomatic narcolepsy. Narcolepsy is irresistible sleep. But for exam point of view, these three are the most important. And in this, again, one more very, very important question from immunology. They have aquaporin 4, this thing, on astrocyte cell membrane. And in the treatment, we use IgG2 monoclonal antibody for the treatment of neuromyelitis optica. They are aquaporin 4 antibody for those who are these antibodies. These are the antibodies. Okay, so we use in those patients where these antibodies are there. So this is a new drug. This is a prospective new question. P and Q, examiner always want to ask the latest drug. So sterilizumab is the new drug. Prospective new question for you. Make a box of this also. Question number 7, INI CET question. Tongue fasciculation is seen in which of the following condition? Muscle atrophy, spinal muscle atrophy, Guillain-Barré syndrome, and myasthenia gravis. Well, when we say fasciculation, this we see in any condition where we have lower motor neuron lesion. Well, this occurs in both these conditions, lower motor neuron lesion. But tongue involvement is a feature of spinal muscle atrophy, is not a feature of Guillain-Barré syndrome. Well, very tricky question. Had been that like fasciculation, then both answer would have been there. But examiner will not give you all the two options having same answer. Here, so it is tongue fasciculation. So let's talk about, well, we all know very well that spinal muscle atrophy is a type of motor neuron disease, is a variant of MND is motor neuron disease. We call as progressive spinal muscle atrophy, where only lower motor neuron lesion is there. Primary lateral sclerosis, where only upper motor neuron lesion are there. We have both upper and lower motor neuron, we call it amyotrophic lateral sclerosis. Then we have progressive bulbar palsy, where cranial nerves are involved and we have lower motor neuron lesion. Then we have a pseudo-bulbar palsy, upper motor neuron involvement. Remember, in these two conditions, cranial nerve are involved, lower motor neuron and upper motor neuron. This is due to corticobulbar disease, which reflects upper motor neuron dysfunction. How we treat MND? We use xyluzole or edaravone we use for the treatment of motor neuron disease. So this is the one where in the option given only this one where tongue can be involved, and that can lead to what? The best answer of this question is spinal muscle atrophy, because these are not the tongue is not involved. What is pseudo-bulbar effect? This is the rank number 1 question. This you should know. Inappropriate and involuntary laughing, crying, it affects social relation. Very, very important point. This you should know. Let me explain to you. There is one patient who has got pseudo-bulbar palsy. This one, pseudo-bulbar palsy. And he goes to a party. In the party, he is supposed to enjoy, laugh, dance, but he starts crying there. It's an abnormal behavior. In the party crying, or he goes to a funeral. In the funeral, he is supposed to cry. Here he laughs. This is an abnormal behavior. And this is known as pseudo-bulbar effect. Okay? And this is seen in pseudo-bulbar palsy. Rank number 1 question. Question number 8. A pregnant lady at 20 weeks of gestation comes with the complaint of acute onset fever, pain in the right lumbar region, associated with chills, nausea, vomiting. Urine analysis revealed E. coli and diagnosis of acute pyelonephritis is made. Which of the following is incorrect regarding management of acute pyelonephritis in pregnancy? Latest INI CET question. The right answer is, well, options are 4 options. You can take a click. Which of the following is incorrect regarding management of acute pyelonephritis? The right answer is discharge if afebrile for 72 hours, continue antibiotic for 5 days. Well, acute cystitis and pyelonephritis should be aggressively treated during pregnancy. We give oral nitrofurantoin and cephalexin are good antibiotic choice in treatment in pregnant women with asymptomatic bacterial cystitis. But for pyelonephritis, we got to give parenteral antibiotic. Discharge is not allowed just after afebrile phase. Complete elimination of pathological bacteria is essential. It's mandatory that all the bacteria should be killed before patient is discharged. Otherwise, the bacteria can regrow and can even lead to gram-negative septicemia. Gram-negative septicemia. Well, how to treat a case of hospitalized patient? IV antibiotic followed by 7 days of oral antibiotic therapy. We give fluoroquinolone. We can give aminoglycoside ampicillin, although it is not a remember, here I am talking about routine hospitalized patient, not pregnant patient. Point to be noted, I am talking about hospitalized patient. How to treat a case of, because this drug is usually not given in pregnancy, because that can lead to bony problem in the child. Third generation cephalosporin we can give safely. Okay. Right? So this is how we are going to treat a case of, this is one of the best drugs to be given. Third generation cephalosporin is one of the best drugs to be given in pregnancy. Other drugs we give in the non-pregnant patients. Question number 9. In atrial fibrillation, okay, this again INI CET question. Newer oral anticoagulant are used to moderate to severe MS. Newer oral anticoagulant are contraindicated in prosthetic valve. Patient with ischemic stroke due to AF should be started on anticoagulant. All patients with atrial fibrillation who are not candidate for cardiac surgery can be started on beta blockers. Well, what is the right answer? Options are there A, B, C, D. Well, in this case, option D is correct. That means B and C. B and C are, these two are correct. That means NOAC are contraindicated in prosthetic valve. We never give, because in such cases they cause increased bleeding tendency. So remember, it's a rank number 1 question. Newer anticoagulant, they are contraindicated in valvular heart disease. And patient on ischemic stroke should be started on anticoagulant. NOC, make a box, NOC are contraindicated in valvular heart disease. Now, what are the newer drugs? Prospective new questions. New question. Vernacalin and donidrone are the 2 new drugs for treating atrial fibrillation. So there are 2 boxes that you should make. Question number 10. Correct sequential arrangement of events in the cardiac cycle starting from diastole. neat question. What the correct sequence? A wave in JP, S1, rapid ventricle filling and opening snap. Okay. I hope the right answer is B. This is the one. So let's learn the basic physiology of cardiac cycle. This is a rank 1 question. It's an easy question, but people commit blunder mistake. And let's learn the basic concept. Here the heart, mitral valve is there, tricuspid valve. When diastole start, this valve open. Remember, normal opening of valve produces no sound. But in severe mitral stenosis, when the valve open, it can produce opening snap. It can produce opening snap. This is the first thing to happen. Okay. Then rapidly blood enters the ventricle. This comes the rapid filling phase of myocardium. 70% blood come into the ventricle from the atria. Rapid filling phase of both the ventricles. Now, on the right side, in JVP, you get wide descent. On the left side, you get third sound. Normally it is not produced, but whenever it has to come, it is third sound. That's why third sound is also known as filling sound. That's why the wide descent corresponds to third sound. Both are produced in the early phase of diastole. In the late diastole, the atria will contract. Both the atria will contract. And they will push. 70% of the blood came in the early phase. Remaining 30% of blood will come due to atrial contraction. And this is known as atrial kick. This is known as atrial kick. That will push 30% of the blood into the ventricle. And in the right side, in JVP, S4 will be, there will be A wave will be produced. We all know A wave is produced due to atrial contraction. And on the left side, normally no sound, but if sound has to be there, it will be S4. That's why S4 is also known as atrial sound. And now A wave corresponds to S4. This is a very, very important box. Make a box. Okay, so a quick recap. Opening snap, rapid filling phase, wide descent, third sound. Wide descent and third sound both come in the rapid filling phase. Atrial kick due to atrial contraction that pushes 30% of blood. A wave produced on the right side. S4 produced on the left side. And A wave and S4, they are produced in the late diastole. So now you are clear about it. And A wave, late diastole, and after that S1 is due to closing of the mitral valve. Which of the following can be used to determine the acid-base disturbance? Well, the answer is A only. Why this? First of all, remember, acid-base disturbance, you use arterial blood gas analysis. We collect arterial blood sample. Look into this picture. This is a bright red arterial sample. This is a venous sample. Whenever we have to do ABG, remember it is ABG, arterial blood gas analysis. The right answer is arterial pH only. Venous pH normally we do not use in clinical practice. We never take venous pH, right? So this and as far as PA2 and PCO2, they are not taken in assessing arterial blood gas analysis. Okay, it's a simple but easy question to remember. Just remember, we always take arterial blood gas analysis. We can take from radial artery or we can take from femoral artery. This is a beautiful question from biochemistry, best way to assess HbA1c level. It's a question from biochemistry, latest question. Answer is ion chromatography is uses HbA1c. But now I have one more question for you. This is the rank number 1 question. In which diabetic condition HbA1c is not used? The answer is we do not use in pregnancy and in hemolytic anemia. They are the two conditions, important conditions where we do not use HbA1c. In these cases, we use fructosamine. Fructosamine tell you the sugar value for the last 2 to 3 weeks. And HbA1c tell you the value for last 2 to 3 months. Okay, make a box of this line. Question 13. You are getting a patient accidentally consume 8 tablets of digoxin. Heart rate 56, ECG shows 3rd degree heart block, that is complete heart block. What is the best line management? It's an easy question. Answer is digoxin immune, Fab, what we call it DG-Fab. This is the best answer of this question. So in this case, we are getting 3rd degree heart block. Why do you say heart rate is 56 per minute? And in such cases, we first line treatment is to give DG-Fab. Remember, there is no role of dialysis in digoxin poisoning. This is a very, very frequently asked question. Dialysis is not, reason being 99% of the digoxin is attached to tissues. Hardly there is anything in the circulation, so there is no role of dialysis. Earlier side effect is nausea, vomiting. Visual disturbance, yellow-green discoloration is very common in digoxin toxicity. This again a very frequently asked question, VIP question. This is a frequently asked question. Now, in ECG, you get ST segment depression, so-called hockey stick sign or reverse, hockey stick sign or so-called reverse tick mark sign. Look into this. This is the normal recording. Now, in this ST segment get like this. ST segment get depressed, so-called hockey stick sign. Okay, this is a classical finding that you get in digoxin toxicity. Well, rank 1 question. Rank in digoxin toxicity, all types of arrhythmias can occur or blocks can occur, except flutter doesn't happen and type 2B block does not occur. Rank number 1 question. Bigeminy is very common. One more rank number 1 question. Non-paroxysmal atrial tachycardia with variable block is a characteristic finding. That there are 2 rank number 1 question in this particular slide. Don't miss it. Now let me tell you what is bigeminy. This is a normal recording. Normal recording. But in bigeminy, normal recording VPC. Normal recording VPC. One normal beat and other is ventricle premature contraction or ventricle premature beat or ventricle ectopic. This is bigeminy. Bigeminy is a very common side effect of digoxin toxicity. Question number 14. A case of suspected acromegaly come with pituitary tumor overproduction of growth hormone. Surgical removal is incomplete. What is the first line treatment of this patient? Well, it's a case of acromegaly. The right answer is octreotide. Octreotide is it is somatostatin analog. What is somatostatin? Is the one which inhibit is all growth hormone. Is also known as growth hormone releasing inhibitory factor. The analog is octreotide. Okay, so that's why even if surgery is not done, the first line treatment is octreotide. Then we have a growth hormone receptor antagonist pegvisomant. This is a second line treatment. And dopamine agonist bromocriptine, because growth hormone, of course, it has nothing to do with growth hormone. But growth hormone is often co-secreted with prolactin. So that's why we give bromocriptine or cabergoline to reduce prolactin level. But however, in this case, the first line treatment is octreotide. And I told you surgical treatment is surgery, but surgery has already been done. Which route we use? Transnasal, transphenoidal, endonasal, transphenoidal resection is done. So remember, this is to have a rapid treatment, but in this case, surgery was done incomplete. The best treatment is octreotide. Boxes. You can make a box. Lovely boxes are there. Well, let's look into other option. This is a rank 1 question. Leuprolin is used to treat prostate cancer, breast cancer, endometriosis, uterine fibrosis, and early puberty. Rank 1 question. Make a box of this also. Prostate, breast, endometriosis, uterine fibrosis, and early puberty. We have nefarelin, is a gonadotropin releasing hormone agonist we use for endometriosis and early puberty. Again, a rank number 1 question. Don't miss out. They are latest drugs. Again, a rank 1 question, which is used to suppress production of sex hormone, breast and prostate cancer, is again injectable gonadotropin releasing hormone agonist. So we are getting good amount of rank 1 question in this particular question. I hope you have written. A 40-year-old male comes with a protrusion of chin, excess sweating, impaired glucose intolerance, enlargement of hand and feet. Is a very easy question. The question itself tells you acromegaly. Growth hormone receptor antagonist. This question we have discussed earlier, but it's a repeat question. You can see. So now you can imagine how in the last 3 years only you got this question twice. Treatment of acromegaly. Pegvisomant is the receptor antagonist I told you in the previous question. And octreotide is a somatostatin analog. I discussed this question, so no need to write. But just to inform you, octreotide, which is a somatostatin analog, we also not only we use for acromegaly. This is a very, very important question. We also use for secretory diarrhea. We also use for varicose bleeding because it can lead to vasoconstriction. We also use in neuroendocrine tumor and neuroendocrine tumor or gastropancreatic tumor we use. So there are many other uses of octreotide. This is a VIP topic. Other than acromegaly, uses are a VVIP topic. Cabergoline is a dopamine agonist we use for prolactinoma. I discuss. This is a new drug. Okay, VIP topic. Olkigepant is a calcitonin gene-related peptide antagonist. We are well aware that these are involved in the pathophysiology of migraine. So we use in the treatment of acute migraine. This is a VIP topic, new drug, prospective new question. Olkigepant, CGRP antagonist. Question 16. This is a lovely question. I'll give you 30 seconds to think. And ABG is done, pH, bicarbonate, CO2 and bicarbonate 35. What is the answer? INI CET question. Okay. Write down the answer. Well, pH is 7.21. So it has to be acidosis. Either this or this. This cannot be alkalosis. PaCO2 80, so it is respiratory acidosis. What about this metabolic acidosis? Can it be? No way. Bicarb is 35. This cannot be. This cannot be metabolic acidosis. Simple question but tricky question. Around 70% people commit mistake. They may go for metabolic acidosis. Lovely question. Very simple but lovely question. Now, so let us learn. If PCO2 is increased, this is the feature of respiratory acidosis. If PaCO2 is reduced, this is respiratory alkalosis. Increased bicarbonate, metabolic alkalosis. Decreased bicarbonate, metabolic acidosis. Since the pH is 7.21 and CO2 increase, hence the best answer is respiratory acidosis. Bicarb is increased but pH is also increased, so this cannot be metabolic alkalosis. Question 17. A diabetic person who recovered from COVID 2 months back now develops severe hemifacial pain, predominantly in jaw, and one of the teeth has become loose. Next step in the management will be. Well, it's again latest question, INI CET question. Options are there in front of you. HbA1c, serum ferritin, MRI brain and nasal swab. The answer is MRI brain. And I'm sure many of you have gone for this answer, but the answer is C. Well, is a mucormycosis is a common diagnosis in post-COVID immune compromised patient. It most commonly infects the nose, sinuses, eye and brain. Right? So mucormycosis is a fungus. So let's talk about rhinocerebral mucormycosis. Rhino means nose, cerebral means brain also. As I mentioned you, it can involve the nose, sinus, brain also. Caused by fungus, potentially fatal. And treatment is amphotericin B. Now I have a question for you. Write down the answer quickly. Which electrolyte imbalance can happen when we are treating a case of amphotericin B? This is the rank 1 question. The question, I repeat the question, which electrolyte imbalance which electrolyte imbalance can happen when we are using? Okay, you can very well write down the answer and later on you can WhatsApp me at my number. WhatsApp me your answer. Right or wrong is immaterial. Note down my personal WhatsApp number. You WhatsApp me. I'll be very happy to give you the answer. Okay. So don't forget. Soon after the class, you can send me which electrolyte imbalance may occur when we are treating a case of amphotericin B. So we go for MRI with contrast. Nasal swab can be used to detect mucus but does not tell the extent of infection. So investigation choice is MRI. This is a typical picture. Just see nose involved, nose, eyes involved. This you can see one of the face is involved. Question 18. A patient posted for hernia surgery complained of fatigue. EC showed depressed T wave with ST segment depression. U wave most likely diagnosis. It's an easy question, but it's a frequently asked question. The answer is hypokalemia. So let me tell you what happened in ECG finding. This is a normal recording. P wave, T wave, ST segment. When hypokalemia start, initially, T becomes short and a U wave appears. In the advanced stages, T disappears or may become flat. U wave appears. Prolong QT interval. Prolonged QT interval, and there can be this P wave, and there can be prolonged PR interval, and you can say this is a P wave. Sorry, little bit. The P become tall. This is pseudo P pulmonale. Pseudo P pulmonale. This is the rank 1 question. Tall P wave without right atrial enlargement. And finally, prolonged PR interval. Very, very important question. Don't forget VIP. And this line is a rank 1 question. Okay, this is hypokalemia finding. Now let me tell you what happened in hyperkalemia. Hyperkalemia. Okay. So hyperkalemia, this is a normal recording. When hyperkalemia occurs, first finding is tall T wave. This is the T wave, tall T wave. First finding is tall T wave. Then comes the prolonged PR interval. PR interval become prolonged. Then P disappears. P wave disappears, so-called atrial arrest. And finally, prolonged QRS, finally wide QRS, so-called sine wave. This is a VVIP topic. Almost every alternate year this question comes. What the question they ask? Well, what are the earliest finding? Tall T wave. In which electrolyte imbalance P disappear or atrial arrest occur in which condition? Sine wave is seen in which condition? What is the correct sequence of abnormality? The different ways question can be asked to you, but it's a very, very important question. And remember, in sodium, maybe hyper or hyponatremia. No specific EC changes are there. Remember, brain sodium disturbance primarily involve the brain cells and potassium involve the cardiac tissues. Question 19. A patient presented to emergency with altered sensorium, irregular pulse. There is only one condition where we have irregular pulse, that is atrial fibrillation. If you are getting this, you are getting atrial fibrillation. This is the atrial pulse deficit of 20. This is again seen in AF. And in AF, A wave is absent. It's a very simple question. Can't afford to miss this question. It's a very easy question. A wave will be absent. Cannon wave are seen where right atrium contract against the closed tricuspid valve, like closed, like complete heart block. Rapid X descent, this we see in cardiac tamponade and constrictive pericarditis. CT stand for cardiac tamponade. CP stand for constrictive pericarditis, complete heart block. And absent Y descent, this we see in cardiac tamponade. In cardiac tamponade, we get absent Y descent. So they are very important question regarding JVP. Now I have one more question for you. Write down the answer. Again, you have to WhatsApp me the answer. When you WhatsApp the answer, don't forget to write your name and college also. In which condition you get non-pulsatile JVP? Non-pulsatile race JVP. Non-pulsatile race JVP is seen in which condition? WhatsApp me the answer. I'll be answering to you. Okay, lovely question, but it's a very frequently asked question. You want to get, you know the answer or don't know the answer, don't worry. Right, wrong is immaterial. Do try to answer the question. Not correct sequence statement about Brown-Sequard syndrome. Well, the right answer is A. This you will not understand unless we know the basic neuroanatomy. Here is the cut section of the spinal cord. This is the central canal. Here are the pain touch temperature fiber. They cross to other side, travel upward. They cross to other side and travel upward in spinothalamic tract. Similarly, first order neuron, they are the first order neuron. First order neuron. Second order neuron, they cross to other side. Here is the posterior column which carries position vibration sense. They enter the cord and they travel upward in posterior column without relay. And here comes the corticospinal tract. And they relay in anterior horn cell. I'm just drawing the diagram of spinal cord, not the detail, but this diagram is worth $1 million. Now in Brown-Sequard syndrome, whenever you get a question, a person was backstabbed, with a knife. If you are getting this, you are dealing with Brown-Sequard syndrome. Here there is a cut in one half of the spinal cord. In the option complete transaction of spinal cord, no, it's one half. How patient will manifest? Ipsilateral loss of position vibration. Ipsilateral upper motor neuron lesion, but contralateral loss of pain, touch and temperature. This is so-called Brown-Sequard syndrome. Make a box of this. In the exam, read the boxes. Brown-Sequard syndrome is a very frequently asked question. Those same box, ipsilateral loss of position vibration and upper motor neuron, contralateral loss of pain, touch and temperature, Brown-Sequard syndrome. Remember, you are getting a question on patient backstab in spine, you are dealing with Brown-Sequard syndrome. Question 21. You are getting an obese person with BMI 30 and he has a picture like this. What is this? It's an image-based question. It's a simple image, but it's a very frequently asked question. This image will come to you also. The answer is metabolic syndrome. Why? What is this? This is acanthosis nigricans. Well, the question examiner can ask you, remember, again go back. It is in the nape of the neck, back of the neck. What people say, and this can indicate metabolic syndrome. Now that new concept has come. Tell the barber, nai ko bolo. Tell the barber if he happened to see this type of pigmentation at the back of any person who is doing hair cutting, and he should tell the patient that, tell his client to go and consult the doctor because he picked up acanthosis nigricans. This can be seen in metabolic syndrome. The feature of metabolic syndrome are obesity, waist circumference of 40 inches in men, 35 inches in females. Elevated triglyceride, impaired fasting sugar, diabetes, low HDL, elevated BP, hypertension. One more way the question asks, all are seen in metabolic syndrome except will be raised LDL. Raised LDL is usually not taken as a part of metabolic syndrome. Lovely question. In atrial fibrillation, NOAC are used in moderate to severe MS. I think this is a repeat question. We already have done it also. Is a repeat by mistake, is a repeat question. Sorry, it was the error of my computer operator. We already done it. Okay. Novel anticoagulant are dabigatran and 10A inhibitor. Rivaroxaban is a new thing. We have done this question, but I am giving you extra information. They are not used in prosthetic valve, as I discussed earlier. We never use. They are contraindicated in prosthetic valve. We discuss, and ischemic stroke patients should be given atrial fibrillation. But new information. This is a VVIP question. They are oral anticoagulants. Dabigatran, rivaroxaban, apixaban, endoxaban. They are oral anticoagulants. Well, warfarin was an age-old oral anticoagulant, but they have more chance of bleeding. But remember, these are not used in valvular heart disease. Question 23. Gold standard investigation to diagnose myocarditis. Well, answer is biopsy. It's a gold standard investigation for the diagnosis of myocarditis. What are the causes of myocarditis? It can be infection Coxsackie, HIV, diphtheria. This is very, very important. Rickettsia, Candida, Protozoa helminth. Immune, post-viral, post-streptococcal, that is rheumatic fever, everybody knows. It could be a hypersensitivity. But in the end, sarcoidosis. Out of all these, don't forget diphtheria and Coxsackie. They are the two more, only thing what you got to remember in this slide. You forget everything, I don't mind. But forgetting Coxsackie and diphtheria is not acceptable. Question 24. A 45-year-old male presented with history of bilateral lower limb weakness with progress to involve upper limb in a year. He had weakness in both lower limb and left upper limb, positive Babinski sign, absent deep tendon reflexes, sensory loss and autonomic dysfunction are absent. Most likely diagnosis. So we are getting motor weakness. Positive Babinski sign, absent deep tendon reflexes. So we are getting a mixed picture of upper motor neuron plus lower motor neuron lesion. No sensory loss, no autonomic dysfunction that we see in amyotrophic lateral sclerosis. In multiple sclerosis, sensory is involved. Okay. Guillain-Barré ka, this is only lower motor neuron type of palsy. Plantar are not upgoing. So, this suggests of amyotrophic lateral sclerosis. Why? You get upper motor neuron lesion, that is spasticity, increased reflexes. Plantar are upgoing, Babinski positive. In this case, Babinski is positive. Fasciculation, asymmetrical distal weakness, it is there in our patient. We can have pseudobulbar effect, the point I told you. Abnormal behavior in the funeral, he laughs, in the party he cries. And bowel bladder are not involved. Okay, this is classical. This is a very, very important point. For bladder involvement is a feature of multiple sclerosis. One more thing, bladder bubble are also not involved in Guillain-Barré syndrome also. But in Guillain-Barré syndrome, Babinski is never upgoing. Okay, and treatment we discuss, riluzole or edaravone are used. Then we talk about topical spastic paralysis. The one more option is a rank number 1 question. HTLV1 associated myelopathy, spastic syndrome, and but no element involvement. It's never element, right? So this cannot be the answer. Finally, the last question of the day. Which of the following does not show both hyperkinetic and hypokinetic movement? INI CET question. The answer is Huntington chorea. Predominantly, it shows hyperkinetic movement. And this is due to loss of interstitial, GABAergic and cholinergic pathways. Okay. Huntington chorea is autosomal dominant, usually manifests in the age of 30 to 50 years. Parkinson has both hyperkinetic and hypokinetic. Hyperkinetic in the form of tremor. Hypokinesia is bradykinesia. Wilson disease again has dystonia and tremor, hyperkinetic, and Parkinson is hypokinesia. is a VVIP topic. Whenever you are getting a patient below 40 years with feature of Parkinson, think about Wilson disease. Whenever you are getting a patient below 40 years with Parkinson-like feature, think of Wilson disease. And rank 1 question, neurodegeneration with brain iron accumulation. This is a panthenate kinase associated with neurodegeneration. Most common form of NBIA. There is a dystonia as well as Parkinson and spasticity. This is a rank 1 question. So friends, I tried to discuss some important topics, gave you many boxes. Read these boxes before the exam. Minimum 10 to 12 questions will come from what I taught you in just 80 or 90 minutes. If you are able to 10 to 12 questions, that means you are going to get 40 to 48 marks extra. Oh, that can change the table. So read these notes very carefully. How was the session? Reminding, second time, 10 to 12 questions will, minimum 10 to 12 questions will come from today's session. Do send me the feedback. You can contact me for guidance for your exam preparation. I gave you my WhatsApp number as well as email ID. Do send your Harvard session. I will save it as souvenir, and I can give you many videos, free videos to watch. Very, very important videos from which you will bound to get lot more question. If you want to get, write WhatsApp at this is the number of my staff, your name and your college, and I'll be telling her to send you many of the free videos which will be getting extra mark, 40 to 48 mark I told you right now. But if you want to go up to 100 marks extra, okay, send message to me or to my staff. This Medicine Simplified is a mini Harrison. You can recommend your juniors to read this book. This book is available in Amazon, Mini Harrison. Just to inform you, DBMCI also does MRCP 1 MLE, Medicine Simplified, which is Mini Harrison, and Smart Medicine, recorded lecture of Mini Harrison. One more thing you should know. Do you know about MRCP? Is a world-recognized postgraduate degree of medicine of UK. You can do super specialty in UK without any entrance exam. You can do MRCP with your current job. Only requirement is internship. All of you have done internship. Everyone who has done internship can write MRCP. You don't need to go to UK for MRCP. We have online course for MRCP 1 and 2. Even if you are doing MD in any subject, suppose somebody doing MD physiology, he can continue MD physiology, you can write MRCP. Somebody doing MD PSM, you continue MD PSM, you can write MRCP. Somebody doing a job as a medical officer or anything, you can write MRCP. Finally, let me introduce to all of you to the owner of my institute, my boss. Ganpati ji is the official owner of my institute, DBMCI. I request my boss to shower blessing to all my young friends who are watching this video so that you get success and happiness throughout your life. So I hope you all enjoyed the session. Don't forget to send your views. How was the session? I'll really save your mail as souvenir. And of course, don't forget to answer 2 questions which I asked you, and I'll be sending you many more videos so that you get 50 extra marks. Total 100 marks from one class, not a bad offer. Thank you very much. God bless all of you. I'll be waiting for your mail, okay, and your WhatsApp message also. Thank you very much.